Hello everybody and welcome to Burdon Kemp seminar series from menstruation to menopause, and today is our final seminar in the series on menopause. We hope to break the silence on this very under-researched area and something that's very under-resourced as well. We've worked very closely with the Spinal Injuries Association on this project, and a massive thank you to them. Just by way of housekeeping, the seminar today is being recorded, however, only panelists are visible. We invite you to ask questions using the chat function, and we will put them to our speaker at the end of the presentation. That now just leaves me to introduce today's speaker. Finding a speaker on this topic was a challenge, but our speaker today is definitely the right person. Miss Iyengar is a consultant general obstetrician and gynaecologist at Buckinghamshire NHS Trust. She trained as a specialist in menopause care in 2018. She runs a menopause clinic and sees people with all medical needs. Her aim is to educate and empower women so that they can make informed decisions. Over to you, Miss Iyengar.
Thank you very much. Thank you very much for inviting me, and I am very grateful to get this opportunity. I'd like to first of all thank Ms. Felicity Ashworth, who is a retired consultant in Buckinghamshire, and she introduced me to the team both at the Spinal Injuries Association and at both Burdon and Kemp. I would like to thank the library staff at my trust because, to be honest, until now, I didn't have much information about how menopause will affect women with spinal cord injury, and they helped me research, find papers so that I was able to look at the right data and information. Not that there's a lot, but I was able to find whatever was there. Karen Mickelson from SIA, and also Victoria Rhiannon and Vicky Moore, thank you very much for your help. So what I thought I'd do is I'd initially start with saying, what is the menopause and why is it a problem? How do you know whether you're in the menopause or not? What can you do? What are the treatment options? And some controversies, because there's a lot about HRT that's been in the press. And how will it affect you in person? How will it affect women with SCI? So initially, before I start with this, I'd like to say that there is not a lot of research, there isn't a lot of data, first of all, with menopause itself, and secondly, with looking after or treating menopause in women with spinal cord injuries. There are very literally handful studies. So I might not be able to give you information and the correct and definitive advice or information about spinal cord injuries, but I can give you, I mean, my talk is generally about menopause and a little bit about women with SCI, and as I go along, I will try and include what happens to women with SCI. So what is the menopause? Literally, it is a pause in the menstruation. So the last menstrual period. It is a retrospective diagnosis, so you only know a year after the period that was the last period, and that now you're officially in the menopause. Until 1 year after the last period, you could be in the perimenopause. Now this can start at any age in the 40s, and it can continue from 5 years to 7 to even 10 years. So it is not, nobody can tell you how long the perimenopause is going to last for, and you can have a variety of symptoms whilst you wait for this last menstrual period. The average age is 51. The study done in 1999, most of the data also is American, I have to say, or Canadian. There's not a lot of UK data on women with SCI. So in the study in 1999, they found that 7.9% of women who had periods before spinal cord injury had permanent cessation of periods after. So in about 8%, they were fine before the injury. After that, no periods. And in about 10% of women, within a year after the menopause, they had no periods. So in total, it's about 14.6% of women within a year after injury, they become menopausal. And what that study found is the average age is 43.5 years, which is more than 7 years earlier than somebody who doesn't have spinal cord injury. Smokers reach menopause 2 years earlier. I always like to mention this because I don't think, apart from not having much information about menopause, I think there's even less information about women who undergo menopause early, that is below the age of 40, and that is called premature ovarian insufficiency. That is in 1% of women, and for these women, it can be quite a devastating diagnosis. In the general population, between 40 to 45, the age of menopause, if they become menopausal, this is called early menopause. Under the age of 50, HRT is recommended in all women. The benefits of HRT when women are younger outweigh the risks, at least until the average age of menopause. So I have some statistics, and I have to say I've picked them up mostly from the SCI website. And from Karen as well. So 20% of acute spinal cord injuries are in women. At the moment, there are 50,000 people in total with SCI in the UK, and of which 2,500 are diagnosed every year. Interestingly, only 1 in 3 are able to access specialist care, which is not a very good statistic. 1/3 who were referred to the Spinal Cord Injury Center were female, and the average age group for most new injuries is 55 to 59. Why is it important? So a couple of 100 years ago, we became menopausal at the age of 45 approximately, and then we died. So it was not an issue. Menopause was not an issue. Postmenopausal health was not a thing. Now women live on an average until the age of 82. Menopause is 51. And so 1/3 of life is in the menopause. So it is quite a significant chunk of life. And more women say they'll want to live a good, healthy life, not just live longer. It's the same data in women with SCI, that they're living longer, and even after their injury, they're living longer. Women live longer than men, and they want to live a healthy life. So that is why menopause and post-reproductive health is important. So how do you know whether this is the menopause or not? So it is your symptoms mainly. Most of them are due to estrogen deficiency. So the lack of estrogen, which is one of the 2 female hormones that we have. I have put in bold the ones that will affect women with SCI. There are about 60 to 70 symptoms that women can get in the menopause, and some women will get some women will get others. I had one woman this morning who said, I've not had a hot flush or a sweat, but my mood is low, my energy is low, my libido is low. This is not me, but I haven't had a hot flush. So I was like, that doesn't matter. You know, you can have different symptoms of the menopause, and everyone is different. So in SCI, there may be the data that I read suggests that the reporting of symptoms is less. There are various reasons they're mentioned about this. This could be because they don't realize this is due to the menopause. Women think this might be due to SCI, because autonomic dysreflexia can mimic symptoms of the menopause. Spasticity can mimic symptoms of the menopause. Vaginal dryness can happen. Intercourse might be painful. Maybe they are used to some of these symptoms, so they don't think that this might be menopausal. And also there is a lack of information, lack of communication. It is something that is not spoken about. They might find that other complications are more troublesome. So that is why that is one of the those could be the reasons why they don't report the symptoms quite as much as maybe women without SCI. And when they mention these symptoms, then it is always important to rule out all of these other things. Now, one of the things that does happen to the skin, which would be probably more relevant in women with SCI, is that there is reduced blood flow to the skin, and that happens to everyone. But if you are on a wheelchair or your skin is under pressure for long periods of time, then that can affect the health of the skin, reduced elasticity, and so skincare is also extremely important especially in the menopause. The other symptoms are vaginal and urinary symptoms, and I know this is particularly troubling for women with SCI. So genitourinary syndrome of the menopause is coined for symptoms that happen both in the vagina and the urinary system. So in the vagina, you get dryness, you get atrophy of the vaginal mucosa, the skin becomes less pliable, less elastic, and more sore. Sex can become painful, it can be itchy. Also, you might find that you're needing to go for a wee all the time, and you have symptoms suggestive of a bladder infection, but actually when you dip it or when it is tested, there is no infection. So the symptoms mimic a bladder infection, but this is basically because of atrophy or lack of estrogen. Now, this is a little bit of biology. I like to start with this. What it tells you is the two hormones that I mentioned, estrogen and progesterone. So there is a cycle, and you've done menstruation not long ago in one of these webinars, so I'm sure you know about this. So estrogen increases in the first half of the cycle, then the egg is produced, and then the progesterone is secreted. At the end, after 14 days, if there's no fertilization, both of these hormone levels drop and you get a period. Now, I have this chart where the top of the chart suggests this is a cycle, and it is every 30 days, so it is over 6 months. And this is a regular cycle giving you regular periods. In the middle bit, this is what happens in the perimenopause. You have no idea whether you're coming or going, what is happening with your hormones. They're up and down, they're all over the place. So you might find that 3 or 4 months, your cycles are every month and you feel fine. And then 3 or 4 months, your symptoms are bad, and then they're fine again, and then they're bad again. So the reason behind this chart, or this erratic nature of the hormones, is the reason why we don't recommend a blood test to diagnose the menopause. In able-bodied women, this is over the age of 45, that they don't need to have a blood test and they can just have treatment. Whereas in women with SCI, I would say that if you have symptoms and you've ruled everything else out, then it is worthwhile treating. What are those? So those were the short-term consequences. What are the long-term consequences? Younger women, because they have estrogen, they have really low levels of heart disease and stroke. Men are more prone to it than women. But as we get older and we don't have the hormones, our risks of cardiac disease, stroke, heart attacks, all of them go up. And that is the commonest reason why most of us die. And because of various reasons, apart from the menopause is one, but also reduced change in the body composition, perhaps, less exercise in women with SCI, their risks are higher. Osteoporosis, the bone density is maximum when in the 30s, perhaps, the bone density reaches its peak in the 30s, and then it starts declining. After the menopause, in everyone, there's a 40% lifetime risk of fracture, which I think is huge. Women with SCI are more prone to osteoporosis. They have less weight bearing, and they might be on other medication. Cortical bone is the bone on the outside in long bones, and it's the hard bit, and trabecular bone is the bone on the inside, that's the soft bit. So there's decline in the density in both of these. What I don't know is whether the estrogen will help in improving the density in women with SCI. What I know that estrogen does help in women with, in all women, maintaining the density and maybe improving it as well. There is definite fracture prevention, so protection against fractures whilst women are on HRT. And this protection, even after HRT, is, although the bone density doesn't improve, if you stop the HRT, the fracture protection still lasts. So this is just a graph showing the peak bone density in the 30s, and then it drops, and then the steep decline after the menopause. So how do you know whether you're in the menopause or not? As I said, it's mainly the symptoms. The blood test that I would do would include thyroid function, because having low levels of thyroid hormone can give similar symptoms to menopause. Above 45, as I said, it's not indicated, and it can be difficult in women who are on hormones and they don't have periods. So that would have to be individual, and that we would need to see, or maybe stop the hormones and see what's happening with the periods or your symptoms to see whether you need, whether this is the menopause or not. So what can we do about it? So menopause affects all women differently. There is no one size fits all. It depends on how bothersome your symptoms are, what your risk profile is, and what treatment option you would like, if any. And some women are absolutely against any hormones, and some women are open to knowing, whereas some women say, okay, I have one woman who said, give me estrogen through the drip. I love it. So I feel very strongly that unless you know what options there are, how can you decide what is right for you? So this is my thing, that, this is why I'm here, is to inform you about the various options. Lifestyle, extremely important. It's not take this pill and you'll be fine. Important to have healthy diet, consistent exercise routines. Your symptoms can improve with weight loss if that is something that you need. Reducing alcohol, caffeine, substance abuse, stopping smoking, all interesting, fun things you have to stop. Not really, but you know what I mean. You have to have adequate calcium and vitamin D. And this is good for your general health, but also your bones, your heart, and also help in your menopausal symptoms. As you may have seen a recent documentary by Davina McCall, this was really good. I thought it was a good documentary, and she's discussed lots of the things that I'm discussing today as well. So these are other things that you can do: lowering room temperature, dressing in layers, and I think laughing about it or talking to friends and having other people you can talk to, opening up the conversation is important. So non-medical options, there are various options. CBT has got huge benefit. All of these other options are also available. I would like to mention this website called Women's Health Concern, which has a lot of information, good information. It is the women's arm of the British Menopause Society. And that also has an information leaflet on how you can do CBT on yourself. But these are all the options that you can use to help going through the menopause. Herbal treatments, so black cohosh, St. John's wort. You have to be careful if women have breast cancer or tamoxifen. There is not a lot of data about its benefit, but these work on some women. What is important to know is that when you buy one preparation, look for the THR logo, because there's some sort of quality control and standardization. What you don't want to do is buy 2 boxes and you have completely different preparations or concentrations in both those boxes. So at least this gives you satisfaction that what it says on the box is in the tablet or is in the pill. Phytoestrogens, these are plant-derived estrogens in soy, lentils. Again, the data is poor quality. I would see women who've tried everything and it hasn't worked. So that is when I see them. But these are also options. What you have to remember is these work because they have estrogenic activity. So if you want to avoid estrogen, then going on for this is not really, you're not really doing what you want to avoid. So what you want to do. So basically you're using a different form of estrogen, but it does the same thing. So it will increase your risks. And so therefore we wouldn't recommend this in breast cancer survivors. Non-hormonal medicines, so women with breast cancer perhaps, or those who don't want to take hormones, can have various other medication. Most commonest ones are a very small dose of antidepressants. There is benefit of these more than placebo, but not as much as HRT. And it's not used on an antidepressant dose. So when I say to women antidepressant, they're like, no, I don't want to have this. It's not for depression, but it is to help with your vasomotor symptoms, help with sleep, help with mood. But again, they don't work for everyone. So what about HRT? We've all seen these headlines, and there is such a scare factor. What I want to do is go back to the history. I think this is really important. So it was initially given in America, and what was found was that women who took estrogen had reduced heart disease, reduced strokes, reduced osteoporosis. And that came with the big headline, "Stay feminine forever," typically American, I guess. And they did observational studies and found that, estrogen is good. But when they gave only estrogen in women who hadn't had a hysterectomy or who do have a uterus, they realized that estrogen alone thickens the lining of the womb and can cause cancer of the lining of the womb. So then they added progesterone, and they realized that the benefit of estrogen is slightly reduced by adding a progesterone. So they decided to do this study, which is the Women's Health Initiative. They realized that breast cancer was a risk, but it was a recognized risk, and the benefits outweigh the risks. So when they did this study, they found that there was an increase in strokes, heart attacks, breast cancer. Then they did the subgroup analysis and realized that so what basically they did was 70% of these women were over the age of 60 or 65 even. They had been without any HRT for 10, 15 years. So what happens is, in the menopause, our vessels, they harden and they get furring. They start getting furring inside the vessels. When you give estrogen, they become pliable and soft again, and they throw these furry plaques, and then you get heart attacks and strokes. So they gave women HRT for the wrong reason. They gave it to prevent long-term conditions, and they gave it at the wrong time. So those women who had had nothing for 10 or 15 years, then giving them this HRT caused problems. So when they did a subgroup analysis, they realized that those women who had HRT earlier, so this is the timing hypothesis, which is in my next slide. So timing hypothesis, they realized that if you start HRT less than 5 years after the onset of menopause or under the age of 60, this does not increase the risk. Under the age of 50, benefits definitely outweigh the risks. And what they found after is, if you start HRT over the age of under the age of 60, it does not increase the risk of heart disease. The other thing they found on my previous slide is that actually, if you start HRT early, this might give them protection from heart disease. They also found that there was a reduction in osteoporosis. And in those women who had had a hysterectomy, they only had estrogen, and they found that there was a reduction in breast cancer for these women. So it's not quite as simple as HRT is bad. If HRT is given at the right time to the right person for the right reason, then it has benefits. So what is the current thought? The pendulum is in favor of HRT. If women have symptoms and they are struggling, they don't need to struggle. They can take HRT. Ideally, it should be started around the age of the perimenopause, around the age of the menopause. And really, it would depend on your personal history, personal risk factors, what you want, what route of treatment you want, what do you prefer. So it is not as if HRT is good or HRT is bad. So what we do in HRT is we replace the estrogen. It is basically hormone replacement therapy. So replacing the two hormones. It is 90% effective in treatment of symptoms. In women who have a uterus, you add the progesterone. If there is no uterus, they don't need progesterone. They can just take estrogen, and they only get the benefits. If women have vaginal or urinary symptoms, then you add vaginal estrogen. And some women will say, I don't want to have the systemic estrogen and progesterone. I'm just happy taking vaginal estrogen. And there are no risks with vaginal estrogen. So you can take vaginal estrogen because it is pretty safe. I will mention testosterone in a minute. So what does HRT do for bones? We know that it maintains the bone density in the spine and hip. As I mentioned, on stopping HRT, bone loss resumes, but fracture protection may persist. And in younger women, HRT is licensed for osteoporosis prevention and treatment. For cardiovascular disease, again, if HRT is started early, then they have a reduced risk of cardiovascular disease. And if you start HRT later, then there is no benefit in the cardiac problems, but there's no increase in cardiovascular events. So cognition, there is some observational data that HRT may reduce long-term risk of Alzheimer's and dementia, but we don't have definitive data at the moment. We shouldn't be starting HRT to reduce the risk of dementia. So cancer risks. So what are the risks of HRT? So main one everybody worries about is breast cancer. So this is something that I've taken from another website called Menopause Matters. It is basically a review of lifestyle versus HRT on the risk of breast cancer. So if you can see the top of the slide, it tells you about the difference in incidence of breast cancer in women between 50 to 59, approximate number of women developing breast cancer over 5 years. So 23 women in 1,000 over 5 years will get diagnosed regardless of what they do. 4 more in those who are on combined HRT, 4 less on those who are on estrogen only HRT. So those who have had a hysterectomy and don't need progesterone may have reduced risk of breast cancer. 4 more in those who are on the pill, 5 more in those who drink 2 or more units a day, 3 more in those who smoke, 24 more in those who are overweight or obese, and 7 less in those who take at least 2.5 hours of exercise a week. So it is not just the HRT, it is your lifestyle as well that affects your risk of breast cancer. The other thing to mention is that this increase in risk of HRT of breast cancer on combined HRT was seen in women who had estrogen and a synthetic progesterone. So it's a progestogen, and that is what was given at that time. Since then, we have changed what progesterone we use. So we use body identical HRT. So it is a body identical or a natural progesterone. And in observational data, this has not been found to increase the risk of breast cancer. But we don't have randomized control data yet. So I cannot give you a slide or a diagram to say that you can take this without worrying about breast cancer, because it is still just observational data. Any hormone-dependent cancer, HRT is not recommended, such as uterine cancer. For endometrial cancer, if women have had cancer, then it is a difficult decision to make if they've already had cancer. But in women who don't have endometrial cancer, if they're on HRT, then it reduces the risk. It keeps the endometrium nice and thin. There is no change in cervical vulval cancer. There may be a slight increase in ovarian cancer. I think I have a slide for that, but I'll show that to you. There may be a reduced risk with oral HRT on colorectal cancer. Yes, this is my slide on ovarian cancer and HRT. So 3 women on HRT will get cancer versus 2 who are not on HRT over 1,000 women. So that's a very slight risk. So blood clots, and I think that is also relevant, I guess, to women with SCI because their mobility is reduced. There is definitive data now that if you take estrogen orally, so there are 2 ways you can take estrogen. One, you can take estrogen as a tablet. Otherwise, what we recommend, and we start everyone now on, is estrogen through the skin. So it's either a patch or a gel or a spray now. That's a new one. So anybody who takes estrogen through the skin, it does not increase their risk of blood clots. So if there are 2 women, they will each have a different individual risk of getting blood clots. If they both take a skin preparation, it does not increase their risk of blood clots over their own baseline risk. Whereas if you take a tablet, it goes through the liver and it increases the risk of blood clots. The risk of blood clots can change with the type of progesterone. So if you take synthetic progesterone, which is present in some HRTs, then that can increase the risk, whereas the natural progesterone is better for us. It doesn't increase the risk. If women are already on oral HRT and they have been on it for 1 year, they do not need to get scared and change it, because the risk is the highest in the first year of use, and then it drops down to baseline. Stopping and starting gives you more risk. Personal and family history is also relevant. Again, BMI and smoking, which affects the risk of blood clots. So the British Menopause Society says that the optimum dose and duration of treatment is to be decided according to the severity of the symptoms, the response to treatment, and arbitrary limits should not be placed on the duration of usage of HRT. So going back to the slide, I would say that if you feel HRT is the right thing for you and you're on it, then you can carry on with it for as long as you want, provided everything is going well. It's extremely important you go for your screening, so pap smears, cervical smears, breast screening, and provided all of that is going well, you don't need to come off it just because you reach a certain age. You should not let the GP stop it for you. You can carry on with it as long as you want. I have women in their 80s still on it, so there's no limit to be placed. Again, this is again close to my heart. Premature ovarian insufficiency. Women, I have a couple of women under the age of 20 who are in the menopause. Quite a few women with cancer treatment who are menopausal, and so long as that's not hormone-dependent cancer, they can have HRT. It is strongly recommended. The risk of all-cause mortality in women with early menopause because of cardiovascular disease, osteoporosis, is high. So the estrogen and progesterone is recommended. What we are giving them is the hormones that are naturally produced, and until the age of 51, the benefits outweigh the risks. For these women, fertility issues are quite significant, as you can imagine. If they are younger and they lose the chance of having their own children, then that can be quite upsetting. Just a quick note about bioidentical hormones. So you may have heard about this. There are some clinics, private clinics especially, who will make custom compounded HRT. So they will make their own HRT in their own back room or in their own lab. There is no regulation or standardization for that HRT. What I would like to say is the HRT we give is regulated, there is data about it, and it is manufactured. Although it is in a factory, the chemical compound is the same as what is present in the body. So your patch, gel, or even the tablet of estrogen is natural. There is one tablet called Premarin, which is synthetic estrogen, but we hardly use that anymore. And the progesterone that is present in one combined HRT and also given as a tablet along with the patch or gel, they are all natural hormones. Mirena coil is also pretty good, so that's another option. Side effects. So nothing is without some side effects. Most commonly progesterone side effects. Again, the natural progesterone is better because the side effects are less. Sorry. Commonest side effect is erratic bleeding for about 6 months, and there are various things we can do. Any side effects that you get, they should resolve as your body gets used to it over time. So this is a slide I like because I tell women female libido is not straightforward. It is multifactorial. I can't do anything else. I cannot make you like your husband, but I can give you testosterone. So although there is very less data on able-bodied women, I haven't seen anything on women with SCI. I really think that this is something maybe with the British Menopause Society we should be able to try and do some research on. So our ovaries produce testosterone as well, albeit in really small quantities as compared to what men have. So the preparation that we have is licensed for men. We don't have anything that is particularly just licensed for women, at least on the NHS. There is something now that is available privately. It is licensed for women in Australia, but nowhere else in the country, in the world. How do you know? I mean, how do you know that this is something that you might need? The lack of energy lack of libido, the joie de vivre in life, the enthusiasm is lacking. Also, it is good for muscle and bone strength, mood and cognition. What I found, although in my study, is that initially after an SCI, there is reduction in sexual activity, but it does increase over time, and that includes orgasm. So if that is working for you, great. If not, then HRT itself might help with your libido and energy. But if, in spite of HRT, if it is not helping, then we can add a bit of testosterone. It is something that needs to be done by a menopause specialist. Your GP won't do that. And you need to be aware that it is unlicensed for women. We can give a try for 6 months, and if it doesn't work, then you stop. What are the side effects of testosterone? The commonest side effect is a little bit of hair growth. So that's why we recommend that you rub it into your lower tummy, upper thighs, and then you can epilate as and how you need. Any more side effects or long-term side effects have not been seen. So we have good safety data for testosterone in women for 2 years. So that's something that's certainly to think about. Low libido and vaginal atrophy. If sex is painful, then libido is going to not be present. So in women for whom systemic HRT alone is not effective, or they don't want to take systemic HRT, but they're finding that they have vaginal dryness, sex is painful, then vaginal estrogen can be used. They can use this without progesterone. Progesterone is not needed because the absorption is very minimal, and all studies to date have not found any risks with taking vaginal estrogen. You can take vaginal estrogen really forever, as long as you need it. There is no need to stop vaginal estrogen because it is not one of the things that is going to get better. The symptoms will return once it is discontinued. One of the things that women ask is, how long are my menopausal symptoms going to last? And it is difficult to say. Some women will have none. Some women, they last for about 7 years, but about 1 in 10 women will still have symptoms 10 years after. And I can't tell you, or nobody can tell you, which one of those you will be. So in conclusion, it is important that we individualize care. The younger you are, the benefits outweigh the risks. The recommendation is once you start HRT, you review in 3 months and then every year. There is no arbitrary limit of when to stop HRT, and it is important to discuss the risk versus benefit ratio. If you wish to discontinue the HRT, you can stop gradually or go cold turkey. So if women are on a patch, sometimes they can cut a patch into half and then slowly reduce it. And 3 months later, they will be the same, whether they are stopping it gradually or they have stopped it straight away. We, of course, need more data. And this is my take-home point, is we need more data in women with SCI. We haven't got enough. But I would like to please ask you to all attend screening because that is extremely important. I have a couple of websites where you will get a lot of information. Of course, the CR website is good. I had a look at their recent magazine as well, which was brilliant. So these websites will give you the right information. The DAISY network is for women with POI. Thank you for your attention. Any questions?
Thank you very much. That was extremely insightful, and I can see that we have had some questions coming through. So one question is, someone has heard that keeping the Mirena coil in over the menopausal time can help with symptoms. Is that correct?
If the symptoms are because of, well, not always. The Mirena itself does not have estrogen, so it won't help with lack of estrogen, which is what gives most of the menopausal symptoms. But what the Mirena can do is it can keep the lining of the womb nice and thin so that you can have estrogen along with it. But on its own, the menopausal symptoms are because of lack of estrogen, and Mirena does not have any estrogen.
Okay.
So it's unlikely to help with that.
Perfect, thank you. Another participant has added that she has a spinal cord injury and advanced osteopenia, and she's 47. Should she be starting HRT?
So in the younger age group, the recommendation, HRT is licensed for treatment of or prevention of osteoporosis, treatment of osteopenia. I would say yes.
Okay.
I would say is yes, speak to your doctor and ask them if they're happy to give you HRT. But because the other treatment options for osteoporosis are present, but they don't help with the other long-term consequences of the menopause. So it is definitely something to think about. Yes.
Great, thank you. And someone else has asked, they're interested in the recommendation for HRT in a perimenopause symptomatic 50-year-old woman who has a sister treated for breast cancer. Would that be wise or unwise?
So I would want to know how old that sister was when she had the breast cancer. In women who are under 35 or under 40 even, they might have genetic risk. Anyone who is older than that, whether the risk is because of increasing age and you can't do anything about that, what other lifestyle risks does the sister have? Is she otherwise similar? Was it an estrogen related breast cancer or estrogen receptor positive breast cancer? So there's a lot of information you need. But if the sister was older and she had breast cancer because of age rather than anything else, and there's no other family history, so mother, aunt, grandma, any other siblings, if there is nothing else, then genetically it is probable that she was unfortunate and she had breast cancer. So yes, I would need to know more about that. But if you have symptoms, then if you ask for the body identical HRT, so the estrogen transdermally and the utrogestan, which is the natural progesterone, then that is the best HRT to have as far as the breast is concerned.
Okay, perfect. And we've got another question for you, which is an attendee started bleeding very heavily after her injury and her periods are still regular. She's 50 years old. Should she start HRT and will it help with the heavy bleeding?
So HRT itself won't help with the bleeding. What I would say is consider having a Mirena coil that will help with the bleeding. Also need to know whether there are any other problems such as a polyp or fibroids. Is there any other reason for the bleeding? Often in this age group, it is the hormonal ups and downs that are the reason for the bleeding and nothing else. So once we know that there's no other reason for the bleeding, then for treatment of her menopausal symptoms, she can take HRT. HRT itself will not treat bleeding. And in fact, utrogestan, although it is good for the breast, is not as good as helping with bleeding. So if she wants to take HRT, then I would say for her, if she has heavy bleeding, then go for the Mirena and a skin preparation, so patch or gel or spray.
Great. Okay, that's really helpful. And I think one person has actually commented that they're a T12 and they're on Torstrin 2% gel. And they found that it's helped with their energy and sex drive. And they've noticed they're much stronger as well.
So that's the testosterone gel. That's the testosterone gel. And again, that is unlicensed for women. So you have either a sachet or a pump. So just two different ways of using the testosterone. Yeah.
And they've just commented that they're also on HRT as well.
Yeah. So I haven't found any data to say that HRT can't be used. I just feel that you're a lost tribe and that nobody is, has done any studies. So there is no reason why you can't go on it if that's something you want. I think it's important to know what the pros and cons are.
Okay. One question I have for you, which is obviously you're very experienced in this field, but for people across the country who maybe don't have access to your NHS trust and to you, how can people get this information and discuss this, which seems more advanced than discussing it maybe with their local GP or at the spinal maybe centres? How many people are there that are out there that kind of cover these topics, and how can our attendees reach these people?
So whether you have SCI or not, GPs are really not trained, and I think the more you knock on their door, hopefully they will realize that they can't escape this and that it is a problem, and they need to train, they need to be trained in it. As far as the British Menopause Society website has got find a menopause specialist on there. So you can look at the map. They have a map on their website, and you can find your local menopause specialist. If your GP is not able to help you, or they don't have the information, or they don't feel, I think what happened is with the Women's Health Initiative study, which said they have increased risk of heart disease and cancer and everything, people got scared and they stopped being able to prescribe it. So I think the GPs are just anxious about it, and they don't know enough, and they want to give you an antidepressant because they're more comfortable prescribing that. So if your GP doesn't know, then you can find your local menopause specialist and see if you can get a referral to them. I would say most gynecologists also don't have a lot of, don't have the information. And I do think genuinely that we need to do more studies, and I'm hoping I'll be able to contact the SCI, SIA to see if we can set something up for doing some research and studies on women with SCI. Okay. I think that's the way to go. But equally, while that's happening, the British Menopause Society has a find your menopause specialist.
Okay, great. That's really helpful, because I just can see that there's not very many specialists and very limited information out there for people.
Yeah.
Great. I mean, someone has offered to volunteer for the study if you would like.
No, so, the more I read about it, the more I thought these are all at 1999. There's nothing new, really. They're all old studies. I had one on email, one query. One lady sent a query about how often they need to have bone scans after an SCI. There is no, I haven't found any recommendation of how often they need to have scans. But what I would say is we do a baseline scan, then start HRT if needed, and if patient is happy with that, and then after 3 or 4 years, you repeat the scan to check what's happening with the bone density. So whether it's going up, whether it is stable, whether it's going down. We know that there's a certain dose of estrogen that is protective for the bone. So you need to at least have that much. Younger women need more estrogen, older women need less. And also you need to be, look at all the other things. I think with SCI, you need more calcium, more vitamin D than others. And exercise is very important.
Okay. And would you say that kind of keeping a diary of symptoms, especially for people with spinal cord injuries, may be helpful, especially depending on their level of injury, so that when they come to talk to a specialist, they can explain what the symptoms are where they may not have?
Yeah, I think absolutely. It's always good to keep a diary, and then you have the diary once you started treatment, so you know whether it's helping or not. And also, when are your periods? What's happening with your symptoms? What the spinal team it would be helpful if they can rule out all the other reasons for the symptoms, such as similar symptoms such as of autonomic dysreflexia, about T6. Once we know that it is not any of these, then we know it's menopause. That can be a bit tricky, I can imagine. But in the right person at the right age, starting HRT and seeing whether that works or not is not a problem.
Okay, great. And I think we've got one final question that's coming, which is one of the attendees is unable to exercise currently as she's awaiting shoulder surgery. Otherwise, she's very healthy. A plant-based diet. What should she do about her predicament?
That's a tricky one. I have to say I'm not an expert in spinal rehabilitation and doing exercises. So I would say contact the SIA, who seem to be amazing at giving the information about what exercises she can do. I can help with the HRT and menopause side of it. But hopefully she'll get her shoulder surgery soon. But whatever she can do otherwise, all of it will help. Sorry,
Okay.
that's not, I don't feel
No.
that's helpful, but I'm not an expert in that, so I wouldn't know what to
So just
recommend.
contact the
Yeah,
spinal unit and see if
yeah,
they can give any exercises or some advise on other approaches that could be adopted.
correct.
Great. Perfect. Well, I think that concludes all of the questions that we've had through. So once again, I'd like to really thank you for your time, and thank you again to all the attendees for attending. It was really informative, and we really appreciate you joining us today and breaking the silence on this topic. So that actually now brings an end to our seminar series. We really thank you, everyone, for joining us throughout this journey from menstruation to menopause, and we may well be running further seminars in the future, so keep a lookout for that. Thank you very much, everybody, and bye-bye.
Thank you for inviting me. Thank you.
Bye-bye.
Bye.